Hello, I am Bernard Ho, a fourth-year medical student here to talk in this podcast about psoriasis. Psoriasis is a chronic, scaly, inflammatory skin disease that can affect people of all ages, affecting 1 to 2% of the population. There is a bimodal age distribution, with psoriasis peak age of onset in the late teens and also in the 50s, affecting men and women equally. In children, boys are less affected than girls. In this podcast, we will go through the etiology, the history and examination, subtypes of psoriasis, pathogenesis, and lastly, management. The etiology is mainly unknown. However, genetic, environmental factors, and drugs such as lithium, beta blockers, antimalarials, and NSAIDs can play a role. Other causes include physical and emotional stress and infections. There is a spectrum of how severe psoriasis can be, and the quality of life the patient may experience with psoriasis. Some may be so mild that it is barely noticed by the affected person, and some may even require hospital admission. The patient will present with an itchy skin, which may or may not be tender. They may also describe pinpoint bleeding when they scratch off the scales. This is also known as Auspitz phenomenon. Some patients may develop joint pain, affecting one or more joints, and patient may complain of developing skin lesions along scars of sites of trauma, also described as Kobner phenomenon. A PSAI, which stands for Psoriasis Area and Severity Index, can also be completed. On examination, you may see the following subtypes of psoriasis, as listed in the slide. Let's go through the different subtypes one by one. Chronic plaque psoriasis is the most common presentation of psoriasis and mainly local, affecting extensive surfaces of your knees and elbows, and also generalized, affecting the scalp, trunk, umbilicus, lower back, and limbs. The plaques are thick, well-demarcated, erythematous plaques with silvery scale. Large plaques can be quite resistant to treatment. Common sites where we find flexural psoriasis are such as armpits, groin, umbilicus, folds under the breast, between the buttocks, and around the anus. Because the areas affected can be quite moist, the psoriasis tends to be less scaly and more shiny and smooth. All other characteristics of psoriasis, the erythematous and well-defined borders, are still apparent. A common differential diagnosis for flexural psoriasis is seborrheic dermatitis. If flexural psoriasis is suspected, skin swabs must be taken to exclude candidiasis infection of the skin. Scalp psoriasis, often a cause of severe dandruff, can cause huge social awkwardness for the patient. Although it may cause some mild temporal localized hair loss, scalp psoriasis is generally not scarring and will not lead to permanent balding. Guttate psoriasis, gutta is Latin for teardrops, are numerous small drop-like lesions that can be found widespread over the trunk and limbs. The face, ears, and scalp can also be affected transiently, and the lesions may be very faint. The rash comes very acutely within a couple of days and usually follows a streptococcal infection of the throat. So if guttate psoriasis is suspected, throat swab and anti-streptolysin O titer should be taken. Psoriatic nails generally present with ridging, pitting, which is loss of the parakeratotic cells from the nail plate surface, onycholysis, which is lifting off of the nail plate from the nail bed, subungual hyperkeratosis, which is excessive proliferation of the nail bed and hyponychium, and also oil drop or salmon patch, which are translucent yellow-red discoloration in the nail bed. Nail clippings can be taken and analyzed to exclude onychomycosis, which is fungal infection of the nails. Psoriatic arthritis is a spectrum of joint diseases related to psoriasis with several possible presentations, such as monoarthritis, distal asymmetrical oligoarthritis of the distal interphalangeal joints, dactylitis, which is interphalangeal arthritis and flexor tendon synophytis, rheumatoid arthritis light, arthritis mutilans, which is telescoping of the digits, and ankylosing spondylitis. Psoriatic arthritis is part of a group of arthritic conditions called spondyloarthropathy. While this is out of the spectrum of this podcast, it is worth reading up this topic. Palmoplantar psoriasis forms erythematic plaques with pustules on the soles of the feet and palms of the hands. Although some texts may say Palmoplantar pustulosis is a form of localized pustular psoriasis, they are distinct conditions with different genetic background. The underlying pathology is rapid proliferation of the epidermal cells, decreasing the transit time from stratum basale to stratum corneum. Therefore, there is a shortened cell cycle in psoriasis compared to normal skin. In terms of managing patients with psoriasis, we can split it to preventative, topical, and systemic approach. In terms of preventative measures, we should advise patients to avoid sunburns and avoid drugs that exacerbate the condition, such as beta blockers, lithium, and certain antimalarial agents. Topically, emollients can be used to moisturize the skin. We can also use moderately potent topical steroids, such as Imovate, but variation of potency can be described for different areas of different severity. Tar-based solution or shampoo will inhibit DNA synthesis, decreasing the cell turnover process. Calcipitriol, which is a vitamin D3 analog, can also help. Red patches often persist despite continued treatment. Topical retinoids and dithrenol can also be used to try to manage psoriasis. Phototherapy, using oral psoralen followed by ultraviolet A light, also known as PUVA, or using UVB, can help with if the psoriasis is too extensive and severe to be managed on topicals only. The systemic approach is with immunosuppressants such as methotrexate, cyclosporin, or biologics such as infliximab. But with all systemic treatments, side effects may occur, and routine follow-ups and bloods should be offered. In summary, we've gone through the etiology, history, examination and the different subtypes of psoriasis, the pathogenesis, and the management of psoriasis. Thank you for listening to this podcast.